EMS bursts through the doors with a new patient. This is a 42-year-old male found unresponsive at home with an empty pill bottle nearby. You go ahead and let the nurses know, let's grab 2 large bore IVs, get the patient on the monitor, get some oxygen with nasal cannula, and then you get your opening set of vitals. So heart rate is 38, blood pressure is 72/42, sat 96% on room air, respiratory rate of 18. This patient is afebrile and their D-stick is 48. When you walk in the room, you see a pale, diaphoretic, barely responsive patient. He is not giving you any history. He is barely awake. So you look at these vitals and you say, let's go ahead and hang some fluids. We'll get the pacer pads on the chest, and then if we could go ahead and push 1 of atropine, that would be awesome. You turn to EMS and you try and get the story. So EMS says he's a 42-year-old with a history of hypertension and anxiety. He takes metoprolol and alprazolam at home, and his wife found him with an empty bottle about 45 minutes ago. No trauma, and the wife is on the way, but they live pretty far out. You get your IV access, you send off some labs. So you put in for a CBC, a CMP, a troponin, a lactate, a tox screen, and then you grab an EKG and a chest x-ray, and you grab your ultrasound or a POCUS. So you're ultrasounding at bedside, you see good squeeze, but the LV is slow and weak, and the IVC is full. So the patient's not fluid depleted. And then your EKG comes back, you see sinus bradycardia, but no QRS widening and no AV block. The nurses at this point have gotten the atropine and the fluid in, but there's no response. So you decide to start pacing, and capture is achieved at 70 beats a minute, but the pressure is still 78/40. So you're like, okay, you've done 30 mg per kg resuscitation, we are still real low. So we escalate to norepinephrine, and there is minimal response. At this point, this is refractory bradycardic shock, and it could be nothing else other than a beta blocker overdose. You drop your glucagon 5 milligrams IV push, and 2 minutes later, the heart rate climbs from 38 to 58, and the blood pressure is stable and improving from a systolic of 72 to 94. So this is a good response. You let your nurses know that we're going to start a glucagon infusion at 3 milligrams an hour. But then 10 minutes later, the pressure drops again. So at this point, you decide to start high-dose insulin euglycemia therapy, so 1 unit per kilogram bolus, and then 1 unit per kilogram an hour infusion with dextrose to maintain the glucose between 100 and 150. Pharmacy calls and is like, are you crazy? You say the indication is not for DKA, it's a beta blocker overdose. So they send it down. You also give calcium gluconate. So the insulin infusion stabilizes the pressures to 110/68, the heart rate 68. And you go ahead and give ICU a call for continuous glucose and potassium monitoring and continued high-dose insulin euglycemia therapy. I think beta blocker overdose is a really cool case. Beta blockers slow the heart and drop contractility by blocking beta-1 receptors, and then they also have some action at the beta-2 receptors in the lungs and the vasculature. They also inhibit glycogenolysis, so you get bradycardia, hypotension, and hypoglycemia. And it's classic that this is refractory bradycardia and hypotension to atropine, pressors, all kinds of fun stuff, right? The thought behind this is that atropine won't work because it's a muscarinic antagonist. So it blocks vagal or parasympathetic input at the M2 receptors in the SA node, basically removing the parasympathetic brake and then allowing for unopposed sympathetic ride to increase the heart rate. But these sympathetic receptors are fully blocked in these overdose and inhibited, right? So this system is offline. Levo and epi also won't really work because the primary pathway is through that beta adrenergic receptor stimulation, and it's pharmacologically blocked. Glucagon increases the CAMP using a different CAMP channel independent of the beta receptors. Insulin basically bypasses the beta